It's number one, eat less food.
BP okay, BP normal. அது எக்ஸ்ரே ஒன்று எடுத்து பார்க்க வேண்டியது தண்ணி போட்டு பார்த்தீங்களா ஸ்லிப்பர் பாருங்க அந்த சாஃப்டா சோல் சாஃப்டா இருக்கணும் இல்லைன்னா எக்ஸ்ரே தான் எடுத்து பார்க்கணும் ஏதாவது போன் வளருதா இல்லை
வாங்கம்மா.
சரி வந்தோடனே வந்து கோழி பல் வைக்க சொல்லுப்பா. ஆமாப்பா வைக்க சொல்றேன். ஜெட்டு வைக்க வேணாம்.
சொல்லு நீ.
Good evening. Welcome, Dr. Mohan, sir.
Good evening. Good evening. Thank you so much.
So we'll start in another 10 minutes, sir. We'll
No
start
problem. No
by
problem.
9 sharp, sir.
Yeah, I'm logged in. So whenever you're ready, we can start.
Right, sir. Right, sir.
Thank you.
Yes, sir. Thank you.
Good evening, sir. Can you please share your screen, sir? Just to check the PowerPoint.
Hi, Vijay.
Let me share screen. You seeing it?
Yes, sir. We could see, sir.
Okay, right.
Sir, I'm Dr. Suresh here, sir. Hello.
Hi, Suresh. What a surprise. Pleasure.
Nice.
Pleasure
Yeah,
to
sir.
see.
Thank you.
And I can see Anthony also. Okay.
Yes, sir.
Again,
Good evening.
Seema.
Yeah,
Good evening.
Sandesh is being a disciple of Anthony.
I'm fast becoming his disciple now.
All will be. That is the reason I am roped in. And Sandesh has been a part of UAI for a long time.
I think we're all part of the same family anyway. So it's always a pleasure.
Welcome, Director Suresh sir. Welcome, Professor Anthony sir. Happy to have you here.
Yeah, thank you. Thank you, Sandesh.
We'll start in another 5 minutes sharp, sir.
No problem.
Ready, all set. I'm trying to reach Professor Vichini. He's probably traveling or something. In case he's kind of delayed to join, we'll start with Dr. Sashi first, sir.
No worries. I also wanted to check my audio. Is that okay?
Yeah, it's clear, sir. So, clear.
Okay. Thank you.
I think this is something that we've all picked up from you, Dr. Mohan, to be bang on time. He's saying, everybody wait. We said 9 p.m., so we will start at 9 p.m.
Sir, I always used to be late, sir. My friends used to tell there is something called Anthony Standard Time, which is always late. But Mohan sir is coming. I was there before that starts.
Anthony, I've always seen you coming on time. So I've never seen you coming late at all, sir.
Sir, ask Suresh sir.
Suresh is laughing. Very diplomatically, he's not answering.
No, Anthony comes to the theater a bit late. When all the surgeons start, he comes late and then he joins a very important part of the surgery. He joins. So that is how Anthony works. Actually. He wants the juniors to work and then come. That is one of my way of saying that.
But anyway, Suresh, whenever I've seen him in any meeting, he's always been on time. I must
Thank
say.
you, sir. First person to tell like this to me, sir.
I can only tell you what I observed. So.
Probably these are meetings in the evenings, and I think Anthony will be in time, sir, because he's
Yes.
always working during that time.
Yeah.
In the morning, early part of the morning, or
Probably
probably
more
some
a night bird.
That's correct.
சுரேஷ் சார்
Really.
தெரியாம சொல்லிட்டேன். கம்பெனி ரகசியம் எல்லாம் வெளில சொல்றாதீங்க.
So that's okay. Like, it's the working pattern has been there.
Anthony, you must be the first person telling people that you're coming late when people are telling you that you're on time.
At least he's honest.
Very honest.
Not a very
Sir,
common
all
trait.
these people know me for years, sir. 30 years, 35 years, everyone know me. Suresh sir was my immediate senior in DLO times itself.
I know.
Yeah.
So it's 9 o'clock now, sir. I think we can start
Yeah.
the
Okay.
proceedings, sir. Warm welcome to all the dignitaries joined here for the World Sleep Day CME by Indian Medical Association, Tambaram, and Tambaram ENT Forum. So we welcome you all for this enlightening session, virtual CME. So to start the proceedings, I would request our branch president, Dr. Perumal, to welcome the gathering.
Good evening, all. So I am Dr. Birmal, President a.k.a. Tambaram. As we gather on this occasion of World Sleep Day, organized by Indian Medical Association Tambaram branch and Tambaram ENT Forum and AMS wing of IMA Tambaram. So in the month of March, we have World Women's Day, International Women's Day we celebrated, and World TB Day we have to celebrate, and World Sleep Day, and the other days we are coming up. And why we need a good sleep is not a mere luxury, it's a well-being of individual. It fuels our bodies, sharpen our minds, and our immune systems. It's a silent architect of our health, silently mending the wear and tear of our daily lives. So I welcome our esteemed speakers, Dr. Mohan Kameswaran, known to everyone in Tamil Nadu nationally and internationally for his pioneer work in cochlear implant surgery. And he was awarded Padma Shri Award by our Indian government for his contribution to the Indian medicine. I welcome Professor Claudio Vizzini of Italy, as a pioneer in ENT and head neck surgery and the barbed wire pharyngoplasty and robotic tongue-based surgeries. So I welcome you, sir. It's a global touch of a ENT forum in IMA Tambaram. So we are, scaling heights. There's a trendsetter of IMA Tambaram. Yes, sir. I welcome Dr. Sashidhar Tatavarti, the ENT head and neck surgeon, known for his works in the field of pediatric airway surgeries. He has a special interest in the field of artificial intelligence and wearables in sleep monitoring. So I welcome you, sir. And our chairpersons, Dr. N. Suresh Kumar, upgraded Institute of Otolaryngology at MMC, the Government General Hospital, Chennai. And I welcome Dr. Anthony Irdayarajan. He is my family ENT surgeon. My daughter was operated for tonsils with him. And I welcome you, sir. And our AMS being Dr. Anit and Venkateshan, and our academic vice president, Dr. V.S. Hariharan, for this World Sleep Day program. I wish this program will be a very good success and an international forum to our members. It will be benefited for all our members. Thank you. I welcome you all once again.
Thank you.
So we'll move to the academic section straight away. So to begin the proceedings, we would like to welcome our dear Professor Mohan Kameshwaran sir to give opening remarks about the World Sleep Day. Over to you, Mohan sir.
Thank you so much. I think, first of all, I want to thank the President, Secretary, and all the office bearers of a.k.a. Tambaram for giving us this unique opportunity. It's not every day that IMA recognizes the importance of sleep disordered breathing, although I think it should, but it's a very nice gesture on your part. And we, on behalf of all the surgeons involved in sleep medicine, and I would like to extend a sincere thanks to IMA Tambaram. I would also like to, acknowledge the presence of the chairpersons, Professor Suresh, who is the director of the Upgrade Institute of Otolaryngology, and Professor Anthony, both of whom are like my own family members, and of course, Dr. Vijay Krishnan. And for all of the members of the IMA Tambaram who have taken time out to be here today with us. So, first of all, let me thank you all. The importance of sleep, I think the president outlined very nicely and very cryptically. It's one of the most fundamental processes in the brain, which is there evolutionarily right from the birds and fishes and so on. So all the animal kingdom treasures sleep. It's very important for all of us. So if you may wonder, what is the reason for sleep? Sleep is a time when the brain does its housekeeping work. So all the unwanted things are thrown out, and whatever is required is reinforced. So basically, sleep is a housekeeper for the brain. And if that is not there, you can imagine the mess that will happen in the brain. If you don't have a housekeeper in an institution, you can imagine the mess which happens. So same thing happens in the brain. Brain gets cluttered with unnecessary information, and it doesn't have the ability to process the necessary information. So it's a very, very fundamental process of the brain. And if that is disturbed, it leads to all sorts of long-term issues, not only with the brain but with the whole system of the human body. And interestingly, the way the sleep is designed in various animals is itself a very interesting process. Now, imagine, we have birds, for example, which are migratory birds, and they travel for months together. For example, the Siberian crane travels several months to come to Vedantangal in Tamil Nadu. Several months. So what happens during this period when it is flying? It cannot sleep. So how does it manage the housekeeping function? Interestingly, they have developed the ability for hemicranial sleep, which means half the brain sleeps while the half of the brain functions. And then it switches over. So the rest of the remaining half, which is not sleeping, then takes over to sleep, and the part which is sleeping wakes up and functions. So the bird never leaves its course of flight because of the sleep, nor does it fall down from the sky, but at the same time manages to get adequate sleep to do the housekeeping function. So if you think about phenomena like this, you can understand the very important role that sleep plays in the brain. And if that is disturbed for one reason or the other, it's bound to have consequences. So I think this World Sleep Day being celebrated is very appropriate. And it emphasizes the importance of understanding the purpose of sleep. And for us physicians, I think it puts in perspective the importance of sleep disordered situations like sleep disordered breathing and so on. It's the most common disorder of sleep. And I think awareness of this amongst the medical profession is crucial, is very, very important. If nothing else, at least we have to think of sleep disordered breathing in many situations. We'll talk about it in a minute. So thank you for this opportunity. So should I continue with my presentation now?
Yes, sir.
Are you getting the view
We
of
are
this?
getting it.
Yes, sir. We are getting the screen, sir.
Thank you. So, sleep disordered breathing is the most common cause of morbidity during sleep, and it ranges from there's a whole range from benign snoring without any clinical consequences, when it's actually just a social nuisance, to complete airway obstruction, where there are a lot of consequences. Like in children, it leads to secondary growth impairment; in adults, neurocognitive defects, cardiovascular sequelae, and so on. Now, historically, even though sleep apnea is a 21st century malady in every sense of the word, it is historically very well recognized. It's been there for a very long time. In the Pickwick Papers of Charles Dickens, the classical observation between obesity and daytime sleepiness was outlined. The fat boy of Dickens. Similarly, the Pickwickian syndrome was described as early as 56 and 56 by Burwell. But of course, it was the triad of Gilliminot, Aldrich, and Demont, the French physicians who established sleep, understood and described sleep apnea. And in 1973, they established the first sleep clinic in Stanford. So that was the very first scientific start of the whole discipline. Now, sleep apnea syndrome, we have to understand this terminology. Sleep disordered breathing could be three things. One, of course, simple snoring is just that, is just snoring without any obstructive apneas or frequent arousals. And heroic snoring is usually snoring which can be heard outside the closed doors of the room. Upper airway resistance syndrome is a more subtle form of sleep disorder breathing, where there is no, real apneas documented pathologically, but the patient is symptomatic and then has daytime sleepiness. Whereas classical obstructive sleep apnea is characterized by episodic partial or complete obstruction of the upper airway and during sleep and leads to sleep fragmentation. So there are three types of sleep apnea. One is the obstructive sleep apnea, about which we are talking about today, and the most common, where there is a complete cessation or obstruction to the airflow in the presence of respiratory effort. The person is still breathing, trying to breathe. His respiratory muscles are active, but air is not entering the lungs simply because of obstruction to the airway. The opposite polar type is a central sleep apnea, where there's no respiratory effort at all. And because there's no respiratory effort, there's no airflow. And finally, a mixture of both, usually starting as a central sleep apnea, then becoming an obstructive sleep apnea. Now, generally, this is a very common problem. About almost a quarter of the population is affected. And if you take people over the age of 50 or 60, it rises alarmingly, and much more so in men, almost double the occurrence in men compared to women. Basically, there is a intrinsic dysomnia due to recurrent episodes of airway collapse and obstruction, and leads to recurrent oxyhemoglobin desaturation and leading to arousal from sleep. There are both anatomical and neuromuscular factors which play a part in this. So basically, the upper airway obstruction leads to a turbulent airflow with vibration of the soft tissue, like the soft palate and uvula and fascial pillars and lateral pharyngeal wall. And this is what we recognize as snoring. The louder the snoring, of course, the more the obstruction. So this is a classical MRI. It just shows the normal airway in a patient who's not having sleep apnea, and when somebody who's got a collapse of the upper airway, narrowing in the day. Now, the spectrum, as I said, we have primary snoring or upper airway resistance syndrome or obstructive sleep. These are the three types which we described. Primary snoring is just snoring. There is no oxygen desaturation and no daytime sleepiness. Upper airway resistance syndrome, again, there is no desaturation and there's but the patient is symptomatic in the daytime. It's a very subtle form of sleep disordered breathing. Finally, the classical obstruction, where there's more than 5 episodes of obstruction and saturation drops below 90%, and patient is of course symptomatic. He has daytime somnolence or daytime sleepiness. So some definitions which we need to know. Apnea is cessation of breathing of more than 10 seconds of two or more consecutive breaths. So more than 10 seconds, 2 or more consecutive breaths. In hypopnea, 30 to 50% or half the reduction in the effort of airflow, and in saturation also drops in this condition. In apnea, hypopnea, in apnea index is the number of apneas per hour in an average of 7 hours sleep. And hypopnea index is the number of hypopneas average in 7 hours sleep. So apnea hypopnea index is addition of the apneas and hypopneas put together every hour in average in a 7 hour sleep period. Now, there's also a condition, a terminology we use, which is known as the RDI or respiratory distress index, where this is actually a apnea hypopnea index added on with what we call RERA, which is the respiratory effort related arousals, the number of arousals the patient has. So that also is added on to the apnea hypopnea index. If you have a AHI or RDI more than 5 per hour, that is more than 5 events happening per hour on average, then that is definitely pathological. So it's definitely 30 or more apneic episodes during a 7 hour sleep period, and AHI of 5 or greater. Now, this generally, if you have a AHI or average episodes of apnea hypopnea of 5 to 15 events per hour, then that is considered as mild. Whereas if it's 15 to 30 events per hour, it's moderate, and more than 30 events per hour is definitely very severe obstructive sleep apnea. So this is to show you the pathophysiology where there's an obstruction leading to increased breathing effort and leading to arousal of the patient. Upper and there's reduction in the PCO2 buildup, the rapid increase in PO2. Patient goes back to sleep. And then, unfortunately, this leads on to increased upper airway resistance, again, hyperventilation, and then this leads to upper airway collapse. And finally, once again, patient goes in for apnea and hypopnea. So this is the cycle which now, in the effects of obstructive sleep apnea is, it leads to intermittent hypoxia, and this can lead to oxidative stress at a cellular level and sleep fragmentation. The oxidative stress can lead to systemic inflammation or endothelial dysfunction, and sleep fragmentation leads to reduced quality of life and daytime somnolence with risk of accidents and so on. So what are the causes? It can be at various levels. In the nose, of course, we can have a very significant deviation with allergic changes. There can be polyps. Sometimes when you pack a patient's nose after surgery, nasal surgery, that itself can induce sleep apnea in some of the patients. In the pharynx, there's a whole lot of soft tissue in the pharynx, which can collapse, which can lead to obstruction like enlarged adenoids in children, tonsils, nasopharyngeal lesions, tumors, masses in the pharynx, retropharyngeal masses, enlarged tongue, micrognathia, retrognathia, all sorts of some anatomical changes within the oropharynx. All of them can contribute to obstructive sleep apnea. In the larynx, of course, we can have supraglottic lesions in the tumors, edema, and so on. So basically, there are a lot of conditions which can lead to sleep apnea. But the most common situation in most patients is there's no such tumors or pathology. It is just the lack of muscle tone causing airway collapse in the vast majority of the patients. So the clinical features, most common association is snoring, heroic snoring. It is not mild snoring, but very heroic snoring, which is very, very disturbing socially. And these patients typically will doze off in the daytime. They're sitting quietly without any work. You will see them snoring away. So they have daytime somnolence because they're trying to compensate for the lack of REM sleep the previous night. And there can also be obstructive episodes. Less common symptoms is usually getting up in the morning with a headache. In fact, people who have migraine, it can aggravate the migraine. There can be personality changes, intellectual deterioration, depression, and frequent waking, going to the washroom frequently, and so on. So basically, these are all the the common associations of obstructive sleep apnea, almost all of them will have an associated laryngopharyngeal reflex. Now, laryngopharyngeal reflex, you must remember, is different from GERD. GERD is a lower esophageal sphincter abnormality where the acid reflux goes and patient has retrosternal symptoms. There is changes in the lower esophagus. But in laryngopharyngeal reflux, it is both upper and lower sphincters which are incompetent. So the acid regurgitates into the throat, into the pharynx, which is normally alkaline. So when this goes there, it produces a severe chemical inflammation and a chronic pharyngitis. So these patients will have changes in the larynx. They may have chronic voice changes. They have a feeling of a lump in the throat whenever they swallow. So all sorts of symptoms they'll have. And if you classically examine the larynx, you can make out the changes of laryngopharyngeal reflux. So this is a common association in obstructive sleep apnea. Also, resistant hypertension. Whenever you have a patient who is being treated by a physician and he is not responding as he should to antihypertensives, think of obstructive sleep apnea. Is he having an associated sleep apnea problem? Same applies to coronary artery disease, depression. All of them can be aggravated by obstructive sleep apnea. Other associations are right heart failure with pulmonary hypertension, the so-called cor pulmonale, cardiac arrhythmias, left ventricular hypertrophy in some, even sudden death has been attributed to obstructive sleep apnea. And of course, vehicular and work-related accidents due to the sleepiness during driving. There can also be association with psychiatric disorders, mental disorders, neurological disorders, and as I told you already, one of the common associations is with migraine. And medical disorders like COPD, sleep-related asthma, so LPR, GERD, nocturnal cardiac ischemias. Epilepsy is another classical condition which can be aggravated. The control over it, of medication of the epilepsy can be very, very difficult in patients with sleep apnea. Pediatric obstructive sleep apnea is a different ball game from adult sleep apnea. And children, of course, snore very loudly, mouth breathing. They may have very peculiar postures when they're sleeping. For example, they may be sleeping prone and so on. And many of them may have a recurrent episodes of cyanosis during sleep, daytime fatigue, sleepiness, the school. Some of the children become exactly opposite. Instead of sleepiness, they may become very aggressive in their behavior and very rebellious and aggressive behavior. Some of them have nocturnal enuresis, uh, unexplained regurgitation, vomiting during sleep, uh, and occasionally, these children get diagnosed as children with attention deficit hyperactivity disorder, ADHD. So think of pediatric OSA in these children. Uh, Classically, you see this huge obstructive tonsils with very big adenoids behind. Children who are like, classical syndromic children like Down syndrome, mucopolysaccharidosis. These are all children who are very, very prone for obstructive sleep apnea. Many of the children may have neuromuscular hypotonia as well. So always in pediatric OSA, these are all things you have to keep in your mind. The pediatric OSA is a little different models when criteria is concerned. In adults, we say an AHI of at least 5, that is 5 episodes on an average of disturbed breathing or blocked breathing every hour as abnormal. In children, even 1 is considered as abnormal. So we have much stricter criteria in children. And here is the way we grade it. Even 1 to 4 per hour is mild, and 5 to 10 is moderate, and more than 10 episodes is considered as very severe OSA in children. What about management? Pre-op evaluation is very, very important. When evaluation has 2 goals, we have to have the anatomical diagnosis and physiological diagnosis. The anatomical diagnosis is to find out where is obstruction, level of obstruction, is it one level, multiple levels, and the pattern of obstruction. What kind of collapse is happening? Is it anteroposterior collapse, a circumferential collapse, side to side? What kind of collapse is happening in that region? The other physiological diagnosis to know what type of sleep apnea. Is it central? Is it mixed? Is it an obstructive sleep apnea? How severe is it? How many episodes are happening? So what are the changes which are happening along with? So it's both an anatomical and a physiological diagnosis that you're looking for. So when you're looking at the patients, take the history, you'll look at the appearance, weight, height, blood pressure, calculate the BMI of the patient, history of alcohol, substance abuse, look at all that. thyroid, hypothyroid situations can aggravate obstructive sleep apnea. A good ENT head and neck examination, including the upper airway, the size of the tongue, soft palate, and so on, and the craniofacial morphology. Has he got a retrognathia, the cause of a tongue fall, and so on. Generally speaking, if you have a collar size of more than 17 for men and more than 16 for women, that's trouble. So we always, this is a rule of thumb, of course. There are exceptions, but generally speaking, the bigger the neck size, the more the trouble. And a very enlarged floppy uvula, soft palate. So you can see the typical. That's a soft palate, the uvula hanging around, big hypertrophic tongue base. So all these are things that you look for. The investigations that we do, basically, the most important investigation for anatomical examination is to study the level of collapse or site of collapse. And we do this with nowadays is an investigation known as DISE, or drug-induced sleep endoscopy, where the conditions of sleep are mimicked with drugs, and the site of obstruction is monitored and video format and recorded with the endoscopy evaluation. Sleep MRI also is very helpful because it can also tell us the site of obstruction, and probably both are complementary. Physiological tests are the gold standard, and the gold standard test is a polysomnogram, or what we call a sleep study. So the polysomnogram, as I said, is a gold standard investigation, and level 1 polysomnogram is usually done in a hospital or a sleep lab setting, and we monitor overnight the nasal and oral airflow, chest abdominal movements, pulse oximetry, ECG, EEG, chin electromyography, EOG, and sleeping position. So you get a comprehensive report of all this in the form of a matrix, and this helps to differentiate the type of sleep apnea. Is it central, obstructive, mixed? The severity of the sleep apnea. So it's a physiological evaluation. The classical type 1 study going on in the sleep lab. And this is the kind of matrix that you will be getting. Here you can see the classical airflow, stops. There's a complete cessation of breathing here. And you can see that there is also a lack of snoring during that period. So when a patient who's having sleep apnea is not snoring, it's not a good sign. It's a sign that his breathing has stopped. And after that, of course, there's a desaturation. And when it reaches a low, here it reaches about 80, that desaturation. And immediately the patient has an arousal and once again starts breathing and it goes up. The typical polysomnographic findings, you can see a period of complete airflow obstruction. But the chest wall is moving, abdominal wall is moving, carbon dioxide expired is coming down because there's no more airflow. And you can see that carbon dioxide is also building up. And then as he starts breathing, it gets dropped. Whereas the saturation is slowly dropping. So levels of obstruction, Fujita classified into 3 levels: retropalatal, and retrolingual. This is a mixed combination, and excessively retrolingual, exclusively retrolingual. So there are 3 different types. Often there's a mixture of different levels. And an endoscopic evaluation with fiber optic endoscopy usually tells you the level of obstruction. And this is what is done during a drug-induced sleep endoscopy. So this is a classical drug-induced sleep endoscopy, and you can see the MRI, sleep MRI. This one is the one, and this is sleep endoscopy. Sorry. So the other classification we use is a Ward classification, and where V stands for velum, or the soft palate, oropharynx, tongue base, epiglottis, and based on the severity from 0, 1 to 0 is no obstruction, 1 is partial obstruction, 2 is complete obstruction. So we can have a nice classification of the level of obstruction. This is used during drug-induced sleep endoscopy. Another classification we use is known as the NOHL classification for the nasopharynx, oropharynx, hypopharynx, and for the larynx, and that's the epiglottis. So we can use this classification also. The various classifications are being used by different groups. The treatment, basically consists of medical appliances, surgical, and non-surgical treatment. Non-surgical treatment is the most important, which we emphasize on everyone. It includes weight loss. Generally advise them to tone up their core muscles by working out in a fitness center. and also, give away the lifestyle management modifications. For example, stop using alcohol, substance abuse. So all this, alcohol in a sleep apnea patient is almost poison for the patient because it takes away the level of the cerebral awareness, which is the only thing he has for his restoring his breathing during apneic episodes. Non-surgical treatment, there are also a whole lot of drugs. I won't go into the details, but there's a whole lot of drugs which have been tried, not very successfully, I must admit, but some of them are promising and they're coming in for the future. One of these drugs is the combination of or what is known as oxybutynin and atomoxetine, and this is a combination of drugs which act on the responsiveness of the tongue muscles to hypoglossal motor neurons. And the oxybutynin is useful in REM sleep and atomoxetine for non-REM sleep. And the combination seems to be very promising. The trials are still ongoing. Myofunctional therapy is again a therapy which is now coming into prominence. And there are very many, usually carried out by speech therapists, voice therapists who have already experience with working in the upper airway muscles. And some of them have developed, taken interest in this area to tone up the upper airway muscles. Non-surgical treatment, of course, the gold standard treatment is the CPAP, the continuous positive airway pressure. This was described in 81 by Colin Sullivan. It's a non-invasive, highly effective primary treatment where the simple principle is that a continuous flow of air and pressure provides a pneumatic splint. So it basically opens up the collapsing soft tissue, ensures that the air enters the lung and the saturation is maintained and the carbon dioxide is lowered. So this is, you can see the fragmented sleep in this patient, the sleep matrix. Whereas when you use a CPAP, you can see how it restores back to normal. Surgical treatment, there's a whole lot of surgeries. Again, I won't go into great details, but suffice to know that these are patients who have unsuccessful medical treatment. Very many of them have failure of compliance of CPAP. I think that's the most common indication for surgery in most cases. The poor surgical cases are also the poor cases in general. They are the extreme obesity, lack of physical activity, alcoholism in a patient who won't give up all that. They are bad candidates for surgery also. And you can see here a list of surgeries which I've just, listed out a whole lot of surgeries. Certainly, we won't go into it now, but they're sufficient for you to know that we have today several options for once we know the level of obstruction, type of obstruction, we have very many options which we can offer to these patients. Some of them are very simple options, some of them are more complicated options, but very many of them are very helpful in these patients. Another exciting area now is a possibility of pacing the hypoglossal nerve, which is known as hypoglossal nerve stimulation. This is coming in also and being tried in many places. Where the main advantage is that every time we monitor the chest movement, and it can give a stimulus to the hypoglossal muscles to dilate the upper airway so that air can enter and the collapse can be avoided. This is another device which is also very effective nowadays. Finally, the patients, there is a small proportion of patients who will not respond to anything. Whatever you do, they give CPAP, they won't use it. And these are the patients who are going in for severe, recurrent desaturation, sometimes life-threatening. And in that small proportion, of course, tracheostomy is absolutely, life-saving in these patients. And it's a gold standard. The moment you do tracheostomy, sleep apnea disappears. There is a small group in whom ultimately, when everything else fails, tracheostomy may be the only solution that you can offer these patients. A lot of patients with extreme morbid obesity who have obstructive sleep apnea also do very well with bariatric surgery nowadays. So I have quite a few patients whom I know who have had very severe obstructive sleep apnea with following bariatric surgery have shown remarkable improvement, and many of them may come out of CPAP or they may also come, start benefiting from CPAP much better. A treatment of pediatric sleep disorders, by contrast, is mainly by surgery. That is the main surgery. And the non-surgical treatment, of course, we use nasal sprays and so on. Surgical treatment mainly is removal of tonsils and adenoids and establishing the airway in these patients. The other surgeries are not very commonly done in children. Tonsillectomy and adenoidectomy is the most common procedures. And today we have excellent tools. For example, we have coablators, which can virtually do a surgery without a drop of blood. So all sorts of new techniques have come in to do that. Today, the main indication for tonsillectomy is not tonsillitis or chronic tonsillitis. It is obstructive sleep apnea. And in very young children with obstruction, we may not remove the tonsil, but we may reduce the size of tonsil. So we do what's known as a tonsil reduction. So tonsil is still there, but we can reduce the size so the airway opens up in these children. So many procedures are available. So to conclude, I think the knowledge of obstructive sleep apnea pathophysiology is very important for all medical professionals. And scientific evaluation of both anatomical and physiological factors, that is the site of obstruction as well as the severity of the disease, is important. And polysomnography and DICE are today almost gold standard investigations in these patients. CPAP is a gold standard treatment, but not tolerated by all. There is a proportion of patients, almost about a third of them, would not be continuing with CPAP, although they have benefit from CPAP. And the choice of surgical procedures then carried out in these people, it depends on the type of obstruction and the severity. And finally, genetics is a new frontier in obstructive sleep apnea. And I think it will play a role in the future to assess the risk factors and to determine the prognosis. So thank you all for your patient listening. And once again, a very sincere thank you to IMA, to the President, Secretary, and all the office bearers for giving us this opportunity and for highlighting the importance of sleep disordered breathing. I sincerely thank you all on behalf of all the sleep surgeons who are involved in this area of specialty. Thank you.
Thank you very much, Professor Mohan Kameshwaran, sir. That was a very good overview of obstructive sleep apnea syndrome for us. And we move to the next part of our session today. Professor Vichini has joined us. Welcome, Professor Vichini, sir.
Good morning to everybody. Thanks for the kind invitation.
Thank you. We are happy and honored to have you here today with us, sir. To chair the session, I would like to invite Director of Upgraded Institute of Otolaryngology, Professor Dr. Suresh Kumar. Dr. Suresh Kumar will introduce Professor Vichini to the audience. Over to you, Professor Suresh, sir.
Yeah, good evening. Good evening, one and all. And I'm really honored to chair this session where one of the legend, my mentor, Professor Kameshwaran sir, Mohan Kameshwaran sir is there, as well as another legend, Professor Claudio Vicini is there. And he needs no introduction, but then definitely for the youngsters who are in this, who have just joined us, will be definitely benefited. So, ladies and gentlemen, it is a great pleasure that I introduce to you a leading expert in the field of sleep surgery, Professor Claudio Vicini, with a distinguished career spanning few decades, right? And then Vicini has dedicated his research, his life to research as well as treating sleep disordered patients, which has changed the lifestyle of so many patients. So to have few amount of his achievements, and he is the director of specialist surgery department, primary operating unit of otolaryngology and cervicofacial surgery. So is a primary service of stomatology and oral surgery, Mogagni Hospital, Italy. And is a pioneer in barbed wire pharyngoplasties and transoral robotic tongue-based surgeries for OSAs, and intuitive Europe inspector for TOS. AMS expert in sleep medicine and he has graduated and advanced in medicine and surgery from University of Faisal. So specialist in otolaryngology and cervical surgery, University of Faisal. So national eligibility confirmed researcher, and he is also a national primary otolaryngology eligibility, national scientific qualification, associate professor in otolaryngology. Excuse me for my bad throat. He is a contract professor of surgery of clinical bronchopathy, ENT, University of Pavia, and contract professor of surgery of respiratory disorders in sleep maxillofacial clinic, University of Pavia. So, member of Florida Hospital Nicholson Center, FHNC Global Faculty Board. So, I will definitely share this session with Anthony, Professor Anthony, who is my friend. And over to you, sir, Professor Claudio Vicini, for enlightening us, or rather it will be a useful session. Thank you.
Thank you, Professor Suresh sir. So once again, one of the most senior pioneers in sleep surgery, but the very down-to-earth professor is so passionate about teaching. Professor, we are very eager to have your talk. Over to you, sir.
Thank you, my friend. Thank you. Can you see my presentation is on the screen?
Yes, sir, we are able to see your screen.
It's okay now? Can you see my presentation?
Yes, you are on.
Yes, sir, we could see your presentation.
Thank you. Thank you. Thank you once more for the great introduction by my dear colleague. Thank you to all of you for the invitation today. Today, I try to stress the role of sleep surgeon in the approach to sleep disorder breathing. It's a key point. I would like also to remember you that last October, I changed my affiliation. Now I moved to a new institution that is depicted in this picture. I have a new hospital, a couple of hospitals, and a different setting belonging to some extent to the University of Ferrara. And here, my disclosure. Let me start with this picture. I love this picture because in the center of the picture is my mentor. This gentleman is Professor Lugaresi. He was an outstanding neurologist, and he founded to some extent the sleep medicine. If you have a look to the people, to the attendee, all of them were neurologists. It's some time ago, but it was the story. Neurologists played a very important role in the area of sleep medicine. They founded sleep medicine. After them, we have to stress the role of pulmonologists. This gentleman invented the CPAP. CPAP was another milestone in the history of sleep medicine. And we can't forget the role of the orthodontist. We have to admit that all of them played and are still playing a very important role. We are really standing on the shoulders of giants. So why and how sleep surgeon in this big group of specialists coming from different area? First of all, we have a very important role, I can say a key role in their diagnosis of sleep apnea. Why? Because the people suffering from sleep apnea has something wrong in the upper airways. Maybe a poor tone muscle in the tongue on the throat, or excessive bulkiness of throat tissue, or maybe long soft palate on uvula, and in most of the cases, obstructed nasal airways. All these areas are inside our daily routine. And we have a very simple tool for diagnosing the derangement of this area, the fiber optic scope. In my opinion, the single tool that you have to use in our daily practice is fiber optic scope. With fiber optic scope, we can discover most of the most important alteration in sleep apnea patient. But if I focus only into this point, I will overlook most of our activity. We are engaged in the diagnosis, but first of all in screening of sleep apnea. Anytime that the patient seek our advice for snoring, we have to rule out that behind snoring is sleep apnea. The snoring is just a sign. We have to have a sound information about anatomical situation, but also functional diagnosis. We can inspect inside during DISE. We have beside the anatomical diagnosis, a functional diagnosis. That is what we call anatomo-functional diagnosis, that is the major role of DISE. Of course, our main treatment is surgery, but we are able to apply meds or to send the patient to our colleagues for work with meds, maybe as well as surgery in the same time as multi-level or multi-modal. We can work with positional, and we may run, we will see in the future, a strict cooperation with CPAP and help the patient to finalize the treatment, helping us to weight loss. But the history of sleep apnea start in our clinic. If you have a patient in the clinic, you have to ask if there is something suspicious of sleep apnea. And the endoscopy is a key point. If you have a look inside an oropharynx like that, with huge vertical tongue and enormous tonsils, of course, this patient is suffering from sleep apnea. And if you look inside and you are able to demonstrate a lateral collapse, that is one of the most common patterns, you are inspecting the area and the pattern of collapse in a sleep apnea patient. But be aware, if you don't look inside your patients, and it's not easy for a pulmonologist and neurologist, you may miss a patient like that. It's not a picture. It's one of my real patients. I had to take care of him a couple of months ago. He was referred to me just for inspection and for prescribing CPAP. Unfortunately, he was suffering by a lymphoma. Lymphoma is a risk, and you have to put into account also a different diagnosis, and it was the case of this gentleman. So a key point, when you have a patient, you are an ENT, you have to rule out more difficult diseases. In our area, we have also the possibility to reproduce a spontaneous sleep, inspecting what happens inside during sleeping. It's not a real sleep, it's induced sedation, but it's a very strict model, very close model that allow you to see inside. If you work with the strict rules, monitoring the parameters of your patient, the depth of the sleep, and work in this way, manipulating your patient, you can get very important information for that diagnosis. Of course, we must be really strict. For that reason, a group of friends and colleagues joined together nearby my city, and we were able to develop the European position paper on drug-induced sedation. It's very important to share a common way of approaching the patient, because variability in DISE is very wide, and so to have a reliable guideline are very important. And again, let me stress again that sedation similar to sleep is what we have more similar to spontaneous sleep. That the best way for understand what the behavior of the patient inside. These videos are very evident in order to show you what I'm saying. In this case, you have a typical pattern of lateral collapse that is strangling. You notice that there is a complete obstruction with a lateral vector. In this case, you have a very unusual situation, but not exceptional. You see a very redundant arytenoid mucosa that is sucked in during inspiration, and usually is an overlooked area of obstruction in many patients. Sometimes you have a situation like that, in which in a awake patient, you may suspect that the epiglottis may be aspirated in during sleep, but if you don't perform DISE, you don't do in a perfect way, and it's very evident a floppy epiglottis is very evident during DISE, and even more evident in the other case. All these situations are easily disclosed by TICE that must be operated on in most of our patients. So let me give you a take-home message, very simple. Sleep apnea is a very common clinical situation, especially in our ENT daily practice. Even in your country, as in our country, its prevalence is increasing. And it's well known that if untreated, sleep apnea tends to worsen. We have to stop this worsening. Of course, it may produce significant morbidity, and if you get into the area of severe sleep apnea, it may be also fatal. It's a social cost for the community, but even is more important to stress that is frequently overlooked and underdiagnosed. And the general offer to the whole medical community is strongly recommended, not excluding ENTs. ENT play a very important role. Let's move quickly to the area of sleep apnea treatment. It's very important to stress that any single sleep disorder rehabilitative treatment is a steeplechase. Surgery, CPAP, and oral appliance. We have many problems along the way, many critical steps for any single options. Have a look to the scheme that give you something in common for all the treatment. First of all, any single patient deserves a proper application. You have to choose the best option for him. But after that, it's not enough because the patient must accept what you are offering to him. And when he accepts, you have to check what happens as an early outcome. But it's not enough because you have to follow the patient for a long time, and you understand that late outcomes are nice and not poor. So in any stage, the number of suitable, winning, and cure patients tend to reduce, and we have to work together in this common situation. I used to say that surgery is an alternative option in case of not invasive therapy failure. Many patients doesn't accept CPAP or get into dropout, or they don't use in a proper way. It's the same situation for med in terms of indication, acceptance, dropout, and proper use. Same for positional therapy, and same for weight loss. So surgery offers an additional option, but it offers a very interesting additional option because it may have a very interesting feature in the concept of mean disease alleviation. Mean disease alleviation is this plot of adjusted compliance versus efficacy. And it is interesting that effectiveness is in the square inside the area of compliance and efficacy. Effectiveness is the most important measure of the activity of our tools. CPAP, med, and positional may have, especially for CPAP, and 100% of efficacy, but unfortunately, a much less power in terms of compliance. And is the area of effectiveness. Is exactly the opposite in surgery, that may be a little bit less efficacy, but surgery, when is performed, doesn't need the patient compliance. So what is very important for any tool for approaching the treatment of sleep apnea is the concept of effectiveness. And surgery is very interesting for this respect. But let me get into a very important issue, a never-ending story in the approach to sleep apnea, the scientific evidence of surgery. Till a few years ago, evidence was poor. If you have a look to this paper coming from Cochrane, it reported just in 2009 that the evidence of the activity of surgery at the time was really poor. If we go back to 2005, the evidence was the Cochrane review of any surgery in adults could demonstrate that no real benefit was demonstrated for surgery. In 2003, in children area, was not possible to verify any sound results. 2005, 2003, so just yesterday. And it's very easy to understand because we have a basic methodological difficulty in evaluating surgery in the era of evidence-based medicine. And I would like to mention this very interesting paper published in The Lancet, that is probably one of the most important paper in the world, that could stress the challenges in evaluation surgical innovation. And it demonstrates that we have many items why it's very difficult to run a prospective randomized study in a surgical area. But it's possible, and now we are succeeding. Probably is one of the the oldest paper in the area of randomized study. Is a study about the role of nasal surgery and nasal obstruction treatment in obstructive sleep apnea. And it was demonstrated that it was efficient. It's interesting that one of the most classical paper as a randomized prospective trial is a paper about palate implants that are not anymore used in our practice. I did my personal contribution with the group of Professor Lugaresi, organizing a prospective randomized trial comparing Bimax, that was a very homogeneous kind of surgery, versus ventilation in the subgroup of adult severe obstructive sleep apnea patients. No question that the evidence-based medicine is one of the most important challenges in the sleep surgery, as well as multidisciplinary, the rapid evolution of technology, and the very wide variability among different patients. But here we have to follow the rules of the pyramids of evidence. For that reason, I try to collect the trials in the last 10 years, and I am very proud to inform you that I could collect more than 130 randomized trials in the area of sleep surgery, and for sleep apnea, and again for snoring, 39 papers well organized dealing with snoring. We have also many other papers in a special area of the specialty of the surgery. And we are, all of us are very indebted to this colleague and gentleman, US in the island of Honolulu, in the area of Honolulu, who could publish many of this paper. Macario Camacho is probably the single specialist who wrote more paper about that. Another very important point, we have to think in the approach of the sleep apnea as a team approach. We must be able to help the patient to accept in a better way the CPAP. And we can work in the nose in order to reduce resistance and increase the compliance. Even this approach was underwent a systematic review and meta-analysis that proved to be efficient in increasing the acceptance and compliance of CPAP. It's interesting to review a very traditional surgery like tonsillectomy. Nobody of us, all of us are doing tonsillectomy since a long time, but what was necessary to build up is a sound review and meta-analysis about the role of a simple tonsillectomy in relieving sleep apnea. I'm proud to say to you that this paper was published in 2016 in The Laryngoscope, and it could prove that in terms of EHI and sleepiness, Simple tonsillectomy, if proper selected, is a very strong tool for approaching sleep apnea. No question about UP3. UP3 was probably the horse for all of us for a long time. This paper comes from Sweden, from Karolinska Institute. Daniel Friedberg and Anna Bronwald were the author of this paper. It's a very interesting, also from methodological point of view, a prospective randomized trial with this very strict evaluation of the patient from the PSG point of view. And it was demonstrated that compared to a referee group, even the classical UP3 was very efficient in changing the PSG parameters, but also in improving sleepiness and quality of life. It was one of the first proof, again published in Laryngoscope, so a very sound paper, that the surgery was efficient in helping our patient. After that, many other palate technique could get the sound evidence as a very effective tool. It was the case of expansion sphincter pharyngoplasty that was, and even now is, a very interesting surgery, very interesting technique. Again, I already mentioned Macario Camacho from US. I'm proud to also to mention Ottavio Piccin from Italy. And let's move to another very big chapter in the surgery of sleep apnea, the area of the tongue, body of the tongue, a tongue base. So also glossectomy was checked in a systematic review and meta-analysis. Boyd Gillespie, one of the guru of sleep apnea in US, wrote this paper, collecting an interesting, a very huge amount of paper coming from all over in the world, even with very important authors like Tucker Woodson and Yu Shei Li. And again, even a tongue-based surgery was proved to be a very effective approach. Let me focus into a special way the role of transoral robotic surgery, which was devised by my group in 2008, 2009. Even this very new technique for treating tongue base was reviewed and gave to us a wide number of systematic review and meta-analysis. This group again include among the other Macario Camacho, and again you can see that the diamond is interesting in terms of efficacy. Our group could produce, first author was Giuseppe Meccariello, one of my most talented co-worker, a very interesting systematic review and meta-analysis, giving us a very sound evidence of the efficacy of the technique. And again, another systematic review meta-analysis coming from a completely different group, again, Boyd Gillespie. And again, we could demonstrate that TORS, including in most of the cases, UP3 or different palate surgery and epiglotoplasty, was proved to be very effective in treating, as you can see in this position of the diamond in this group of paper, in the relieving of the problem of the patients. It is so true that probably it's difficult to demonstrate for every patient, but in a group of what we call anatomical favorable patients, probably we have to redefine the timing of surgery. Not in all the cases after CPAP, but in some cases, like in these cases mentioned by Brian, probably in this group of patients, surgery is the first line of treatment instead of CPAP. There are many studies that can prove this statement, but we must be aware that surgery it was proved to be efficient. Sometimes is probably better than CPAP. And for that reason, again, I did my contribution in this additional paper about the same topic. We have to reconsider the first line of treatment for sleep apnea. Again, moving from a systematic review of the literature, and it's the group of the study that we could included in our study about CPAP and surgery, probably working with the data coming from these two interesting group of papers, we must state that probably in a tailored intervention in special individuals may be a first option of treatment even before that CPAP. Another point is how much does it cost surgery compared to a different situation. I'm happy to mention this gentleman that probably most of you remember is Christian Guillermino, one of the most outstanding sleep doctor, a neurologist from Stanford, and he could prove working with the system of QALY that in a subgroup of patients, the initial approach using surgery is more cost effective than the long story of CPAP. So it's interesting because even from the cost point of view, it's as you can see in the comparison of this curve, it may be a better tool to start your treatment with surgery instead of using conservative treatment. So let me give you a final take-home message. ENT surgery for sleep apnea provides an additional option in case of conservative failure, especially if you have an anatomical favorable patient. We have a wide range of surgery able to fit to a wide range of different patients and anatomy. And what I tried to stress in my contribution of today is that we are collecting an increasing amount of evidence supporting efficacy and safety and the sound and the proper use of surgery. Of course, more studies are recommended, but even now we have a large corpus of data with 6 basic surgical options that you have to keep in mind. First of all, minimally invasive outpatient surgery. That is very interesting in the approach of snoring. The workhorse, the palate and tonsil surgery, that probably is the most common procedure that is applied in the surgery. I would like to stress in my experience, but probably it is supported by a worldwide huge amount of literature all over in the world, the concept of multi-level surgery. Even tongue-based surgery is changing. Now we move to the area of resection and suspension to the era of stimulation, but it's changing, but tongue-based remains one of the most important area for sleep apnea surgery. We don't do anymore many tracheostomy, but tracheostomy is anyway a safety approach for very special cases. And last but not least, neuromodulation. I skip a new concept that is getting out very recently, that is the use of irreversible electroporation for reducing the bulky amount of tissue in the tonsil, in palatine tonsil and tongue base, that is right now under evaluation. It's a new, very interesting tool that probably will be very promising in the future. I try to give you an idea that surgery is not anymore an experimental approach without any proof. Now we have very strict evidence that surgery is an additional and very effective tool in your hands. So it's the reason why, in my opinion, ENT is getting a more and more central role in the treatment, in the diagnosis, first screening and treatment of sleep apnea. Thank to all of you for your kind invitation and even for the even more kind attention of today.
So, thank you. Thank you very much, sir, for this wonderful overview and your evidence-based approach. And it is infusing confidence to the surgeons who is starting up with sleep surgery. And we are no more like in many of the meetings where the physicians always say that we are doing more surgery unnecessarily. I think this evidence-based approach and all your research activities have put more confidence in us. Thanks for this wonderful lecture. It's one of my very important lecture that I've heard. Thank you, sir. Thank you,
Very welcome.
Saktesh and Thermal sir, Dr. Hariharan sir, a.k.a. Tambaram for arranging this wonderful lecture. Thank you. And any questions that we can, Saktesh?
Audience can, we don't have any questions in the chat box as
Okay.
of now, sir.
Okay.
Audience
Thank
can
you.
post their questions in the chat box if you have any questions to the speakers.
Okay.
Thank you, Professor Suresh. Thank you, Professor
Yeah.
Vichi, for your wonderful lecture. As usual, it was very nice to hear and see. So your good friend, Dr. Seemab, is here. Dr. Seemab, if you can unmute and say a few words.
Hi, good evening, Professor.
Hi, Simab.
Always a pleasure to hear you. And every time I pick up so many things, but I'm really glad that.
Seemab, sir, your mic is not right. We are not
Okay,
able
is
to hear.
that a little better?
Yeah, it's now better, much better.
Yeah. Thank you, Professor, for joining up with us. And it's always a wonderful thing to hear you, and every time there's new stuff to learn. And I've been communicating with you, so we know that. But it's wonderful, like Suresh said, that we need to bring out this point among our non-ENT colleagues also, that surgery is a very good option now, and it's evidence-based. So thank you very much for bringing that out. Lovely stuff. Thank you.
You're
And it's
very
good
welcome.
to see you. It's good to see you nice and back into full practice in a
It's my
different setup.
pleasure. It's my pleasure to see you. I would like to shake your hands in person as soon as possible.
Very soon, hopefully very soon. I'm sorry I missed out the Oman event, but definitely very soon we will catch up.
Next time.
Next time, for sure.
Thank you.
Thank you, Shaktesh. Thank you, everyone.
Thank you, Seemab sir. Thank you, Professor Vishini. So with that, we move to the next part of the session, which is going to be a very interesting area, which is coming up, the area of sleep monitoring. And we have a person who's very much interested into AI and wearables in the field of sleep monitoring. To chair this session, we have Professor Anthony Irdirajan, Professor and Unit Chief, Upgraded Unit, Institute of Otolaryngology, MMC, Chennai. Over to you, Professor Anthony. Professor Anthony, sir.
Am I audible now?
Yes, sir, you're audible, sir. Over to you.
Yeah, good evening, everyone. It's a fantastic lecture we have heard from Professor Vincini, and I thank our Tambaram branch, Saktesh, and everyone who have given me the opportunity to chair this session. To introduce the speaker, Shashidhar, who is a student of Madras Medical College. Actually, at the time when I was coming in as the professor of Madras Medical College, assistant professor of Madras Medical College, he was a undergraduate student there. He is a head and neck ENT surgeon in the Artemis Hospital, Gurgaon, and also he got his clinic in Gurgaon, Haryana. He is a award-winning, highly skilled, and hardworking senior consultant of ENT and head and neck surgeon, and a vast exposure in this specialty. The state-of-the-art international training and dedicated proactive in patient care, maintaining the highest level of ethics and the optimum utilization of these resources. You can describe him as a passionate learner, excellent team player, with a flair for the research, academic, and teaching. Shashi is trained in Chicago, Illinois, where he has got his ECFMG certification. He's done his MSc ENT in lady hunting Lady Harding Medical College in Delhi, and his undergraduate in Madras Medical College. Its accomplishments are very long list is there, where the Times Award for the best doctor, ENT doctor in NCR, Rising Star Award to Award for 2018 given by the Health Secretary of Union Government of India. And then is the largest series in the world for a rare condition called hemicrania and a transient bleeding syndrome, covered by several new papers and a documentary made by a Discovery Channel. First slide tracheoplasty in LTR combined for the whole length trachea in India in 2015. And first laryngological reconstruction with an LR gap in 2013 in the pediatric age group. He has done the first balloon tracheoplasty in the country and presented in the state conference 2009. The first prize consultant award for the LVA annual conference in 2014 for the laryngotracheal stenosis and endoscopic versus open surgery. Gold medal consultant paper in the Delhi State AOA on laryngotracheal stenosis and an endoscopic versus the open surgery papers there and so on. Got a best paper award runner-up in the International Pediatric Otolaryngology Conferences March 2010 Hyderabad, India for the balloon laryngoplasty in the pediatric subglottic stenosis. Winner of prestigious Delhi State and All India ENT Research Quiz in the 2019. And for his experience, he is an experienced ENT and neck surgery Optimist Hospital, and he is a senior research associate in the evaluation and management of upper airway obstruction in children, Lady Arlington College. And his special interests are phonosurgery and laryngology, general otolaryngology, pediatric otolaryngology, and head and neck conquer surgery. So he is going to talk about the wearables, smartwatches, and the home sleep monitoring present status in the future. I say hi, Shashidhar, and please take the stage and you can proceed.
Thank you, sir, for those kind words. As the alma mater of Madras Medical College and speaking for IMA Chennai Tambaram branch, it's an immense pleasure for me to go back to my roots. I hope I'm audible here. So,
yeah, very much.
Yeah, wearable smartwatches and home sleep monitoring. Why do I deserve to give this talk? Now I'm a student of Indian Institute of Science, pursuing my second year diploma course in artificial intelligence and wearable devices, and that's actually a course. So we have 45 doctors who are enrolled in this course, and all of them are interested in developing gadgets and using AI in the medical field. So anyone who is interested in AI, they should look forward for these courses, and really a good experienced faculty out there. Now, how do I live my life to fullest, happy, healthy, and reaching my full potential? You need exercise for body and mind, nutrition, and sleep. And one of the longest studies which they saw in centenarians, what really matters if you want to live more than 100 years. And they actually, this is a Chinese study, but they kind of published it in ASSM guidelines and journal. And they said you need to sleep more than 7.5 hours a day. And that's one of the fundamental things. But when they say sleep apnea is a big problem, they kind of guesstimate that there are 30 million adults who have sleep apnea, but almost 80% of them are undiagnosed. And how do you pick up them? And that's a real challenge in the world. How do you pick up somebody who's got a sleep apnea? You can have questionnaires, you can have spouse and family version, you can have full-blown PhD studies, but you really don't know what parameters in the sleep are the most important ones. Is it the AHI? Is it the desaturations? Or is it the sleep architecture? So there are hundreds of parameters there which you can look at, but you don't really know which one is the most important one, which one is the fluff, which you can leave out. And that's how the Indian meal is. Like, how do you know you had a good meal? Is it like, the dessert has to be good, or the non-vegetarian part has to be good, or how do you decide it? Just because you have so many items in a meal, it doesn't make the meal a good meal, or you can't really make out what was the real thing. The same in PSGs. There's so many parameters there which all say and point towards that it's a sleep apnea, but you really don't know which one actually impacts the health and which one should be used out of so many parameters to quantify or exactly say the person is suffering from a sleep apnea. And that's where the home tracking devices come in. They kind of work around the basic, which are very important. That's how you feel like you had a good meal. You may eat few things, but you're like, this is your daily meal and you're quite happy with it. Every day you don't want a really big meal. So it's like oxygen, heart rate, breathing rate, movement of your body and wakefulness, and the brain waves to tell you you're in a deep sleep or in a superficial sleep and REM sleep. So my journey started with wearables in back in 2013, where we had these strange cases of bleeding of children, and they would spontaneously bleed anywhere from the body, from the nose, eyes, ears, and after the bleeding episode, they'll be absolutely normal. And the Discovery Channel did a program on them trying to track these kids and see what is wrong with them. And they couldn't really find out anything. And one of those cases came to me, and the challenge was to crack it. What is really wrong with them? So at that time, if you see this girl, she's wearing this watch. It's a basis watch. Only one company in the world, that's called the Basis company. They had this wearable watch in which it could track heart rate sensors, perspiration, movement sensors, and few other things. So I had, my friends imported from US, and we had put it on this kit. And this data was amazing because we had admitted this patient for several days and we couldn't really crack it. But when she was wearing the watch and she went home, you could actually see that her bleeding episodes were right before there's a sudden raise in the heart rate, the perspiration increases, the skin temperature kind of drops. So all those things were like coming beautifully on the wearable watch. And then it had really occurred that they really have one of the most simplistic way of obtaining a data from the patients. And then we knew that propanolol is going to work in these patients, and then we gave propanolol, and he was cured. Then a whole bunch of 15 more cases all over the country came in. Now it's a pretty much standard thing that we give them a wearable, we track their heart rates, and we treat these kids. So fast forward, uh, all the sleep tracking devices are divided into three classes. One is called the wearables, which may be a watch, strap, ring, headband, earphones, chin patches, or even FDA approved home sleep tracking devices. Or they're non wearables, which can be pillows, which can be a mattress pads, which can be like a tabletop appliances, or there's simply some apps on your cell phone or on your computer which can actually track your sleep. And this is the most simplistic sleep tracking device on a watch, which has these sensors. And the most important sensor is called photoplethysmography, which is basically same what you use in pulse oximeter, which has a heart rate sensor, and it detects what is called as a heart rate variability, which is like beat to beat, how much difference in the heart rate can occur. So in a deeper sleep, the heart rate variability is different from a superficial sleep. In awake, the heart rate variability is different. So it tends to measure the stages of sleep by measuring the heart rate variability and cross-checking it with the actigraphy sensor, which is basically your position sensor. If you're moving your hand or your body, these sensors get activated. Then you have a temperature sensor. Then you have a skin conductance sensor, which can tell any sweating or a fluid loss or change in your skin conductance. And then you have last the oximetry sensor, which is where you can see the pulse oximetry of your body. So the newer watches, they have this ECG sensors. You don't have a EEG sensor yet on a watch, but you have a EEG wearable device on your head, which are like straps, which can pretty much do everything. And they are the most accurate ones to give you the sleep stage cycles. And for the first time, the revolution started in 2019, where, the Stanford project took on and the Apple really took it on a larger scale, and they started for atrial fibrillation. But now most of these artificial intelligence are used to see the respiratory rate, which is taken again from the heart rate, sleep stages again taken from the heart rate and heart rate variability. You can measure electrolytes as well, which is basically from the ECG. And we are not doing the temperature ones, but yeah, temperature can be used for detection of COVID-19. And this was the first publication which was kind of aiming at, which showed that, the Garmin watch could actually detect you have a poor sleep, and it could detect the different stages of the sleep. Nobody kind of took it very seriously at that time in 2019, because, they will always come with a disclaimer that, you need a medical device to kind of really act onto it and get the precise data. It was only in 2023 you got a one really good publication, which was from Seoul, Korea, and it was with the collaboration from Lee et al. With Stanford, where they took all these devices uh, and then they analyzed them. And one of the things which I wanted to tell you about the analysis, there's this score called Kappa Cohen's kappa score. A Cohen's kappa score is like how much agreement is it to with the original gold standard. And this is the different parameters, zero point 0.01 to zero point 0.2. Like 0 to 1 is the scale, 1 is like the perfect agreement. Just to have an idea, the world's most perfect marriages have a Cohen's coefficient of about 0.5 to 0.55. So, don't expect our watches to be much more, agreeable than your spouse, but that's how it is. And what they did was they divided the subjects into two parts. It was a multi-centric randomized trial, and they gave them variables, nearables, and aerables. Aerables are the apps. Nearables are the ones which you either tuck it in the pillow or on the bed mat or near the table. Wearables are the ones which you're wearing, and these were the things they were using it. And at the same time, the person was having a PSG, and they were seeing what is the outcome. And these were the things they use. They use the older generation watches. Right now, the technology is way ahead of what they used in this publication. But still, for the purpose of publication, they use a Pixel Watch, a Fitbit, Aura Ring, and these were the apps they used. And the mat, they use a Withings sleep track mat. Amazon Rise and Google Nest were the two nearables which they used. Now, if you see in their data, this is the actual PSG, and the architecture of the PSG is quite really replicated by the wearables, almost same, but at some point it will, either underrepresent or overrepresent a deep part of the uh, sleep. Like in this Pixel watch, I think I'll just use a laser pointer here. Here, if you see it, the deep sleep part is really not there, but it's just overrepresented. So the macro F1 is another scale which is almost similar to a Cohen's, but when the data is very fragmented and you have several classes, instead of using a Cohen's agreement, they use a macro F1 score. And this is a very common term used for artificial intelligence apps and software to kind of predict how well it predicts. So when they compared all of them, it was coming quite good, 0.56. But actually, the surprising winner was the apps. And these are the apps which are, just download on a cell phone and ready to go. And how can they even perform better than a watch which has so many sensors and it is in contact with your skin and which is measuring every 3 seconds, every 2 seconds, taking the data. And that was a very surprising part. So when you look at the matrix here, the more blue it is, the better is the performance. The more orange it is, the lower is the performance. So this is wake period. This is the uh, superficial sleep. This is the deep sleep. This is the REM. This is the sleep efficiency score. So different parameters were seen, and all these watches, they're very good at kind of picking up deep sleep, REM sleep, and uh, the superficial sleep, the light sleep. But where they make mistakes the most is coming at the sleep efficiency score or and all those sleep latency scores. They are not very good in telling when actually you did fall in sleep. So the whole brilliance came with a new patent where actually the cell phone was used like a sonar. And what it did was actually the cell phone was emitting 18 kilohertz sound from the bed or from the nearby table, and this sound was, which is completely inaudible, was reflected by your body, and like a sonar which is used, this signal of the audio which is reflected back, it is again processed by artificial intelligence, and you can actually calculate the breathing rate. And this was the, sonar beat system, which was the most important patent which was filed, which went into all the apps which came by later. And the whole generation of the apps, which I'm showing here, sleep routine, sleep score, then there is Snore Lab, all of them Pillow, they're using this technology. And they're quite all right, except for a few ones which perform the worst, the sleep score. But a sleep routine is almost at par with the wearable technology. And now, in February 9, 2024, actually, Samsung really realized the market, that this market is huge, and it went on to get an FDA approval for its watch, that it's at par with a home sleep apnea test. So maybe this watch is going to be released in October, but the next year you'll see all the watches which are almost FDA compliant. Rather than few publications supporting the watch, you'll actually have a FDA sticker on them that they work well as a sleep test. Now, the first watch which actually did was Fitbit, which kind of went into this, and they were the ones who had the maximum patents, where they use heart rate variability, and their analysis was coming up like a, we can work around, we can predict sleep. But Garmin actually took it to a all new level, and they, instead of focusing on the sleep apnea score or AHI, they focus on something called sleep score, or what is called as what is your score of your sleep. And they use several parameters, including stages, your pulse oximetry, and respiration, and come up this as a holistic score. And that's how the dashboard kind of looks on a watch if you want this for some hours. And you know, the direct correlation of the sleep scores is how much are you feeling fresh? How much is it charging your battery? And this is how it shows a body battery in the next day, that you are 75% charged like a cell phone. And that's a beautiful variable, because if you want to work out, you know how well you can feel. So if you had a few beers, your score can go with the same amount of sleep from say 78 to 47. So it's actually the sleep score which is more important than sleep apnea, and that's what they realize, and now they're focusing on that direction. So Apple Watch is also doing in a similar way. There is a Fitbit, there's a Muse headband. Whoop is a big company which works in the same line. Then there are straps which work in the same line. Uh, the bigger challenge is now the battery ones, how much longer the battery can last. Now you have stickers on the jaw which can actually detect your jaw movements and give you EMG and data to kind of see what sleep disorder you have, like bruxism and other things. So this is the matrix where several, the agreement percentage of several watches. Apple kind of leads it, but this is one of the YouTuber who kind of posted it. But he's got a huge following and he's taken as one of the bigger guys in the uh, domain of the variables. And but if you just see, how the watch compares to an actual EEG, it's quite similar. I mean, the peaks are very well represented in the EEG into the smartwatch. So it is kind of accurate. Now we are reaching up to 80 to 85% agreement on the watches. Now the wearables, either you can use an Amazon Halo or a Somnify or even the Google Nest. They basically record your snoring sound, the breathing movement sounds, the sleep movements, and they have some, at best they can have an 80% agreement. But there are so many privacy issues when you're using these recordable devices because people can talk in their sleep, and once it plays in the next day, it has its own consequences. I think there's another sensor base which you kind of put it under the mattress and it detects your movements. It also gives the same appearances. Now the apps we just discussed that, so I'll skip this for the delay. You also have apps for treatment of sleep apnea, and this is one of the best apps, which is called Airway Gym, which makes you do several exercises of orofacial myofunctional therapy. And my patients really love this. When I asked them to download it and use it, they said it's been very helpful to them. And it also gives you compliance, how well the patient is actually performing the exercises they have been asked to. Then there's another app called Snow Tech, which is basically a small widget which is given with the app, and the patient has to blow through the tongue and do the exercises on it. It is to increase the endurance strength of the upper airway muscle. It's a very brilliant idea. It works well. And there are other apps which will tell you positional therapy, how to sleep on the lateral. If you're sleeping on the back, it will give an alarm, it will wake you up, and so many other things. But these apps have started a new race where the apps are being used as a teacher, as a tutorial tool. So one of the things which we use very commonly in our practice is a simple pulse oximeter for children. And this is what we do for decannulation or any of the procedures we have done, because the child is running around playing in the park and other times, and you really want to know what is their pulse oximeter. So the child really wears it on their wrist and with the pulse oximeter in the finger, so you actually know how are they're getting desaturation or not, what is happening to their pulse rates and everything. So it's a very useful tool. It's not expensive at all, and I really should give it a try to this. The last one is called SAMD, software as a medical device. You have an ECG data or a pulse rate data in your ICU from a pulse oximeter or a ICU monitor. You can actually upload it on a website of Sleep Image, which is an FDA approved uh, app. This was the world's first artificial intelligence FDA approved app ever, and it was given for sleep apnea analysis. What it does is it takes the data and it actually crunches its number, applies their algorithm, and gives you an output where it can predict how much sleep apnea you have. So, whatever the watches were doing with their own proprietary thing, this does on a cloud when you upload the data. They also have their own small finger devices called sleep image rings, and but it gives opens a whole new territory where you can actually use a data which was done 20 years back in some trial, and you have their ECG data or you have their pulse oximetry data. You can use it and predict that if they had a sleep apnea in those patient groups. So it opens all new areas of venue for research. So what's the downside? It's a data privacy. It can give vague errors. Even though you will diagnose sleep apnea reliably. You can't do a CPAP titration with these. Battery is another concern. Every day you have to charge them. Some of them can be actually very intrusive. They're expensive. Uh, so same thing, the watches can give, even if you're standing in Bangalore, it can give that, you have done 30 kilometers on your bicycle, and this guy was on his bike. So, definitive advantages, it makes you in a habit, it gives you a better health. It can be used to pick up other conditions like diabetes, arrhythmias, electrolytes, pulmonary edema. I actually had these apps pick up nighttime coughing for a lot of my patients, and I was able to treat their GRD because of the nighttime coughing. The snoring apps were picking up. So it will tell you this patient had coughed 110 times at night. So you know that it's actually not the sleep apnea which is causing him not to sleep, but it's actually the nighttime coughing. So the small nuggets, these important informations which can be picked up by these apps is amazing. It will give you new insights in your patient's management. And there's a whole lot of commercial HST devices, which, the companies who do sleep study at home, they buy it. Uh, and we use all these kinds. Some are portable, some are in the belt form, some are like stickers in the hands, like Night Owl, which ResMed uses. But they're getting smaller and smaller. That is they have so many features. Some can do level 1, level 2, level 3, level 4. You can actually go and play on the recording later to understand. Now, the future is actually in our course, which we've been taught for the AI course, the textiles are being designed which can do ECG sensing, EMG sensing, and EEG sensing. So soon you'll be actually, none of these devices will be there and the time frame is about 4 to 5 years, because currently the technology is there. It's all about integrating it, where you can have a heart rate, respiratory rate, body temperature, skin hydration. All these things can be done just by wearing this small, uh, you know, a textile T-shirt or a textile body-worn suit, and it can give you all your data. And this is actually Dr. Saurav from our Center for Nanoscience and Engineering. He developed this electronic tattoos. So they are another generation of concurrent technology where the sensors are so small that it can be implanted in your skin. And they probably also give the same data, pulse, blood pressure, EMG, ECG, which can be actually extrapolated to your sleep cycles and so much more. And it's just matter of taking a sticker and sticking it in your hand that you'll be able to diagnose a sleep apnea patient. In conclusion, AI and technology will not replace sleep practitioners, but sleep practitioners using AI and wearable technology will replace the practitioners who are not using the technology. Technology is evolving in 38 billion USD market. So the market of this is growing every year. Data is more important than the technology. So while you are practicing, collect as much data as you can. Monitor your patient with variables and increase. So you're done a surgery, you're done whatever intervention, ask them to monitor them at home with the variables. The cheapest Indian market has noise, which is about 4,000 watch. It does a pretty good job. So you don't have to go and buy the most expensive one. Collaborate and innovate. India is a hub of patient data, skill, and technology. Thank you so much. Happy to help for questions.
Thank you, Sashi, for a cutting edge talk on wearables and the future of AI technology. Anthony, sir, your comments.
Yeah. See, from the most difficult thing, the days of the starting of OSA practice in Chennai are finding a place to do a sleep study. And from that level, now we have come that sleep study can be at your hands on your bed, and you can take it along with you. You can slowly see that. I know. Yeah, Saktesh runs, and for that to monitor his run, he is having a good smartwatch. And so these smartwatch will be the future, as Shashi told. Actually, it's a fantastic idea to get involved in the AI and the wearables in the measurements of your exercise and exercise induced other sleep parameters. And so, any other questions? And I request our director, Professor Suresh Kumar, for any comments.
So it's a real big, sorry, and a real eye opener, right? I congratulate the presenter, Sashidharan, who has been an alumni of NMC. Very proud to be a part of that. And really, AI is making big strides in everything. And it is not surprising that they are doing that in sleep. As Anthony said, it is really yeah, it's very difficult and also cumbersome. Many of the patients, they don't go in for the sleep study. It's because of that cumbersome way that has been done. In future, this is going to be really doing a very big favor to the patients because we are reducing their pain.
Yeah, in next 2 years, we'll have
Yeah,
variables going all the way. Like
yeah.
Samsung
It
got it,
should be like
other versions will come.
that's
And the only
a
problem
real
is
eye opener. Yeah.
you can't bill a patient with a watch. So that's the only problem. You have to find a way there.
No,
Professor
we can
Seema,
find a way, but that when you are doing this, most of us we are finding it difficult to do this home studies as well as even the
Correct.
evaluation.
Especially children, it's very difficult for us to kind of do any sleep
With
studies.
all these gadgets together, they can't sleep. Most of the times, my sleep labs in Stanley Medical College as well as Veterinary College get spoiled because of this doing this for children, and the children pull all these things in the sleep, and
Yeah.
you know all these flimsy wires get tangled and get damaged as well. So
Correct.
it would have been easier to make, and you can just put it on him and just send him off and take off the data after 3 days for the 3 days sleep data variables like that, which is very difficult in the sleep lab at the present situation where he leaves everything and come to the sleep lab.
So the
Very good ideas, very
strategy
heartwarming to hear.
we should increase our sleep labs is not going to work out if we have to cover a country like this. We may have about 400 to 500 sleep labs presently, but it has to go down into the technology base. But surprisingly, the smartphones are actually doing pretty good in actually picking up. And all those snoring patients can be picked up to go and do a formal sleep study.
Professor
Great.
Any other
Thank
questions,
you.
Saktesh?
Seemab sir has raised his hand, sir. Seemab sir, you can unmute yourself, sir.
Thank you, Shaktish. Shashidhar, really mind-blowing and an eye-opener. But you should not give this talk so late at night. You're not going to let us sleep thinking about all this. You should give these talks during the day. Okay, just coming to a question. See, you showed one of those devices which is put under the mattress, right? And they try to use that to get sleep studies. There's an engineer here in Pune who's actually devised that, and they asked me to get on the board of their company to try and validate this, but I could not understand this. So if you can try and please help me, how does a device which is under the mattress give you the saturation? I can understand everything else, but how does that device give you the saturation? What is that technology?
So basically, it's actually extrapolation from when the heart beats, the heart thrusts the chest wall, and that thrusting they take it as one of the parameters, and then they compare it with the thrusting measure. So the saturation which they gave is actually not a true saturation, but in their trial reason, so artificial intelligence works like this. You give it data which is set A, which is and data B, which is completely unrelated. And it's and there's no algorithm for this. The machine learns itself how to correlate it. So if you have driven a car and you have not worn seat belts, the AI can tell you that you have a higher chance of STD. So that's like one of the data they picked up from the health department and the traffic accidents uh, department. But when you look at this, a guy who is actually reckless in the driving will be reckless otherwise as well to get an STD. So it's not the exact ones, but the philosophy is that the heart hitting the chest wall creates that movement, which is picked up by this sensor, and it is kind of taken up. But the algorithm, which was already made, he copied it for his app. He's got no way of explaining it. So it's
So
all
you mean
machine
to
learning.
say they're picking up vibrations and using the vibratory senses to judge the saturation?
Yes. From the normal and otherwise calculated patients. So what is the reduction in those vibration and how much does that affect the
But
saturation?
at your college, are you all by any chance validating this with a regular PSG or with an oximetry to know whether that saturation is even, plus or minus 5% close to what we need to know?
I mean, the validation will happen at your end. That's why he wants you to be on the board. It's not validated. That's why he wants you to be on the board so that you can actually put your stamp as a medical doctor that it works. But it would be interesting for you for this, just for the science of it to kind of see. And surprisingly, like I said, a cell phone giving you breathing movements, a cell phone which is giving your it doesn't give you the saturation, but it gives you sleep stages, which is just lying on a table. That's absurd. But they use a sonar technology where they're giving low frequency sounds and getting it reflected back, and it really works well. So, the machine learning can go either ways. It can completely give you a junk or it can really predict beautifully. So, unless you test it, you'll never know it.
Thank you. Amazing stuff. But thank you very much, Saktesh, Anthony, Suresh Kumar, sir, and everybody else.
Thank you, sir. Thank you for being there.
This topic is a hot topic everywhere you go in international conferences. You
Seriously.
always have a topic on wearables. So I would like to have Professor Vicini's thoughts on the Sashi stuff. Professor Vicini.
Yes, here I am. Can you hear me?
Yes, sir. Yes, sir. We are able to hear you.
Okay, I have some trouble with the camera. It's a very
Yes, we can hear you.
Okay, it's a very interesting topic. I think that is very promising. I am not sure that right now is a reliable way for measuring all the issues that we need to study when we approach a patient, especially from the surgical point of view. But most of them are promising, and I'm quite sure that in a 5 years time, we will have interesting devices, very useful also in the daily practice. So in my opinion, it's a good tool in the near future, probably not yet, but the approach is correct because wearable means that you study your patient at home without constraints. So in the best situation available for study sleep without disturbing. So far, I'm not sure that we have the perfect tool, but I'm quite sure that the next two steps in the near future will be reliable wearable and with a system of analysis that is every day more available, we will have information in an automatic way and absolutely useful for the daily clinics. That's my opinion today. Of course, everything is changing very fast, but I'm quite sure that in a time of 5 years, we will have good tools.
Thank you, Professor. So we have one of my good friend from Forli who did residency along with me with Professor Vicini, very young enterprising ENT surgeon. Tiziano, how are you? Can you share your thoughts on wearables with the sleep?
Yeah. Well, I also believe like hello to everyone. I also believe, like Professor Vicini said, that the wearables are going to be the near future. So 5 years time, it's absolutely going to be there already because it's something that people are really going to be able to use daily. That it's going to monitor more than once a year or twice a year. It's going to be more affordable, more available. So I'm sure it's the future. Well, not yet, not nowadays yet, but in the near future. The AI is working very hard on it, and like they were explaining, AI is really creating the algorithm and everything that's studying the new parameters that we are looking into it, not just the AHI. So yeah, it was very very interesting, the conference. Thank you.
Thank you, Tiziana. Professor Rukmani has raised her hands. Madam, can you unmute and ask your question, please? Professor Rukmani, are you there?
Yes, I'm here.
No, there's another professor.
Yeah.
One of
Oh,
our
sorry.
professors.
Sorry.
Yeah, I listened to your very good lecture. Thank you for this nice lecture. I have a basic question. We all talk about radiation from the mobile phones. What about the wearables? How much radiation it can emit, and that too when a person is going to wear it for a long time? That is one question. Second question is, using these wearables make patients always conscious of their health. Instead of thinking something else, they every day they talk about the number of steps they walked, number of times they breathed. Instead of something other than the self, they will be always thinking of the self. These two things have to be clarified. That's what I wanted to ask.
That's an excellent question, Professor. One of the devices, actually the cell phone ones apps, it requires you to put the cell phone near your head before you sleep, and with a charger connected to it, because it's using the phone's microphone. It is also generating the sound and receiving it. So it's using considerable battery running the algorithm. I would be really very, uh, scared of putting a cell phone near my head, especially when you have so many publications of acoustic neuromas coming with, radiation and everything. And unfortunately, in this really advancing thing, when the guidelines how to develop these products, the radiation standards are not at all there. It's so easy to pass a C radiation criteria, which is, the radiation criteria. If you have a Bluetooth fourth generation, or you have a Wi-Fi 5 or Wi-Fi 6, you pass a radiation criteria that it's safe. But nobody has done a long-term study to kind of really pinpoint they're actually safe in the long term. So that remains one of the biggest, questions about using these radiation devices in front of the small children for monitoring. And I really don't have an answer for that. The second question which you asked was about, sorry, I forgot. What was the
Being
second question?
conscious about themselves when they wear these devices all day.
Yeah, it works both ways, because if people talk about it, they can change. Sometimes it is discouraging for them. But honestly, the insights it gives about your own self is amazing. One of the fundamental things, if you know how your body works, and what really crashes your body, if you log on to your watch and see, it will just really. I thought I was always draining in the OT, but when you put a watch and see, the body battery goes the worst in the OPD. And I thought I was getting tired of the surgery. Surgeries actually was more calming and relaxing. So, a lot of things it kind of change your perspective, because when you look at the actual specifics, the heart rate variability and other things, you actually can pick up the things in your 24-hour schedule. What is generating the stress in you? What is increasing, giving you reward in terms of the health parameters? Is it the meditation or what activities? Obviously, it can give you some stress if you're, too much worried about it. But for the beginners, it's just the data which can make a lot of sense.
Thank you. Thank you for answering the questions. Thank you, Doctor.
Thank you, Professor Rukmani.
Thank you.
If there are no more questions, I think we can go to the vote of thanks. We have had a long session. I invite Dr. Prashant to give the vote of thanks for the session. Dr.
Good
Prashant.
evening. Yes, sir. I'm here. Good evening, sir. Good evening, everyone. We've had a wonderful session. I'm very thankful for being given the opportunity to deliver the vote of thanks. Special thanks to the Indian Medical Association, Tambaram, along with its AMS wing and the Tambaram ENT Forum for conducting this wonderful virtual CME on the World Sleep Day. Special thanks to all the learned faculty, including Professor Dr. Mohan Kameshwaran and Professor Claudio Vicini and Dr. Shashidhar Tatavarti for their excellent insights. And I have special thanks to our chairpersons, Professor Dr. Suresh Kumar and Professor Dr. Anthony, for joining us and moderating the session wonderfully. It was indeed, I being an orthopedic surgeon, basically, it was indeed enlightening for me to listen to all the interesting discussions and the wonderful developments happening in your field too. I think it is going to be an exciting field in the coming future. And last but not least, special thanks to all the delegates who had joined this and made this session a lively one. Thank you, everyone. Thank you for making this a grand event a success. Thank you.
Thank you very much,
so
Prashant.
much.
It was a
Thank you,
wonderful
Dr.
session. We had
Shaktish.
Thank you. Thank you, Sashi. Thank you, Professor Vicini. Thank you, Professor Suresh Kumar. Thank you, Professor Anthony. Thank you, Professor Seema. Thank you, Tiziano. It was a wonderful evening. Thank you very much. So we'll call it a day. Thank you very much, everybody.
Thank you.
Thank you much. Thank
Thank
you.
you.
Bye.
Thank you. Good night, everybody.